Det hörs bra här. Jajamän, det är bra. Härligt. Ja, då om cirka 15 minuter kommer vi köra webcast här från Lund. Och vi kommer börja med Jonas och sen kommer Göran. Och sist kör David. Och vi kommer även ha en frågestund här i slutet av föreläsningen. Jajamän. Och ni är välkomna att höra av er per telefon och sms och via mail. Jättebra. Ja, okej. Ja. Ja.
So, I think it's time to get started. Hopefully everyone is joining in from different sites in the Nordics. My name is Jonas Lundmark. I'm the medical director for Actelion Pharmaceuticals in the Nordics. Good to have you here in the room. It's a quite big crowd. And also I know that there are a lot of sites out there in the Nordics, and actually we have participants from Norway, Sweden, Finland and Denmark. So it's a huge pleasure to host this meeting from Lund today. And we are actually looking into a very interesting topic. We are going to discuss the risk assessment part, and I think that you have heard about it many times before, but it's good to bring it up for another discussion. So on behalf also of Actelion Nordics, we would like to welcome you to this afternoon session that will last for roughly 85 minutes from now. So it's going to be an interesting session, hopefully. I would claim to say that there has been a quite substantial development in the PAH management for the last year, or actually for the last years. Not only in terms of treatment options or available treatment options, but also I would claim in the terms of how they actually are used, where we have moved quite substantially from monotherapy to combination therapy. A little bit also regardless of etiologies. And not only discussing combination therapy from a dual perspective, but also raising the question on triple combination therapy. Another part that has really much developed over time is how we diagnose and how we assess and how we follow up the patients. And one of those tools or one of those approaches might be, of course, how we risk stratify or how we risk assess the patients over time. And that is the main topic for today. It's a huge pleasure to introduce David Kylhammar, who is actually the first author of the register data study that came out from the SPAR register last year. And this was the first publication on data validating and discussing the risk assessment approach, actually the first one in the world. That was followed by 2 other publications just a few months after that, but the Swedish data was first out. We also have Dr. Göran Rådegran here. He will be the moderator of the session, and he is the last author of that publication. So it's very nice to have both of you here to give this presentation. Having that said, and looking into the agenda for David, that will continue for 30 to 40 minutes, and hopefully that will raise a lot of good questions in the audience here and also out on the different sites. This will then be followed by a moderated session, and this is maybe the most interactive and most interesting part, I hope, of this session, because we encourage you out on the sites and we encourage you here in the room to really raise different opinions, different questions that you might have, and really make this a lively and good discussions as good as possible. Well, if you haven't really figured out how to log into the meeting, then I think it's a little bit too late to give you this link, but hopefully everyone is on board right now. And we have 2 different options to raise questions to David and to Göran in this session. Either you send an email to Micke Bergqvist, and you have his email address up here, and you raise your question. Another option would be just to send him a text, and you also have his phone number up here. With your question included. You should also state whether or not you would like to call in to make this a live question. So please write that in your email or in your text, and we will call you up, and then we can have the question just live. That was pretty much my introduction. Great to have both of you here, and I will now hand over to you, Göran, for the first part of this evening.
First of all, welcome to all of you that are here today to this winter webcast meeting on PAH and risk assessment. We're going to see whether the microphone works, and it may be better now. I furthermore would like to welcome all of you that are sitting at the other sides in Norway, Finland, Denmark, and the other sides in Sweden. Welcome to the present meeting. We have definitely prepared ourselves for the present meeting with regards to winter and skiing in Lund, because that's a risky business. This was a competition in the central park of Lund for about a week ago. PAH patients, they also live with a risk. My name is Göran Rodrian, and I'm the head of the hemodynamic lab and PAH ward at Skåne University Hospital in Lund, and furthermore, the head of the Swedish Association of Pulmonary Hypertension, which unify 7 Swedish PAH university centers into the Swedish PAH register, which is a large collaboration. Pulmonary arterial hypertension is a very serious disease that after an initial vasoconstriction is dominated by a vascular remodeling. And you have alterations in the structure of the vascular wall with in situ thrombotisation, and towards end stages of disease, the lumen of the pulmonary arterioles are very small, which leads to a very high pulmonary vascular resistance, right ventricular heart failure, and ultimately death. And with regards to prognosis, before we had any treatments, the median survival in PAH from diagnosis from the date of diagnosis, if untreated, was in IPAH approximately 2.8 years, and if related to connective tissue disease, only about 1 year. But we have had a tremendous development since the mid-1995. And the first treatment that came that was available was epoprostenol intravenously. Thereafter, busulfan, Tracleer came in the early stage of 2000. Thereafter, we had treprostinil intravenously and subcutaneously, followed by inhaled iloprost. We thereafter have PD5 inhibitors with the sildenafil, a single endothelin receptor blocker, ambrisentan, followed by tadalafil, which was a new PDE5 inhibitor. And this was then followed by a new double endothelin receptor blocker, mastetentan, and the guanylase class stimulator, riociguat. And then last year, we had access to a parallel IP receptor agonist, selexipag. So today we have many more choices with regards to treatments that we can give, and we can now target all 3 pathways that are involved in the development of the disease. But when we have more choices with regards to treatment, we have to make smart treatment decisions when it comes to combining those drugs together. So we can combine oral drugs with IV, subcutaneous, or inhalation therapies. In 2015, we had new ESC and ERS guidelines, and those guidelines recommend us that we should treat in relation to risk assessment. And this is something that David Kielhammar is going to talk about in his following talk. I had the pleasure in August this year to co-moderate a session at ESC together with Nazareno Galea, and the focus on that talk was PAH triple combination in a timely manner. And at this session, Stefan Rosenkrantz presented 3 new studies that had been published during 2017. And the first study was a risk assessment study from the Swedish PAH register, followed by the study by the French registry, and thereafter the Compera registry. So I would like to end my part of this introduction, and I will now leave the word to David Kielhammar, who's going to talk about the Swedish register study, a comprehensive risk stratification at early follow-up determines prognosis in PAH.
Thank you. Am I on? Yeah, thanks. And there we go. Thanks. Thank you for having me, and nice to see all of you, all friends from Lund. And nice of you to sit wherever you are and listen to me and us today as we discuss risk stratification in PAH. So my name is David Kielhammar. I am presently a resident physician at the Department of Clinical Physiology at Linköping University Hospital in Sweden. Shortly before I moved to Linköping and started working there about 1.5 years ago, I defended my PhD thesis here in Lund at the Department of Cardiology, and it was focused partly on the modulation of hypoxic pulmonary vasoconstriction, hypoxic pulmonary hypertension, and partly on treatment response and risk stratification in PAH. And after I received my PhD, I, together with Göran, coordinated a study which resulted in this publication in the European Heart Journal, entitled A Comprehensive Risk Stratification at Early Follow-up Determines Prognosis in Pulmonary Arterial Hypertension. And it's basically this study that I will talk about today. Göran and I coordinated it, but we did it in cooperation with representatives from all 7 Swedish PAH centers. And it's based on data collected and registered in the Swedish PAH registry. The Swedish Association for Pulmonary Hypertension was founded back in 2007, and the registry was initiated a year later, initially with financial support from the industry, but since several years back it's a national quality registry where the Swedish Association of Local Authorities and Regions has the economic responsibility. The registry includes consecutive patients or consecutive data from patients diagnosed from 2018 onwards, but also retrospectively collected data on patients diagnosed from 2000 to 2007. Data are collected and registered at the PH centers, but the platform is managed centrally by Uppsala Research Center. As I suppose most of you, or even all of you know, the European Society of Cardiology and European Respiratory Society guidelines on the diagnosis and treatment of pulmonary hypertension recommend regular risk assessments based or to guide the treatment decisions, and they recommend a comprehensive risk assessment using this multidimensional risk stratification tool, which incorporates data on clinical, exercise, biochemistry, imaging, and hemodynamic data with specific cutoffs for each variable corresponding to a low risk, intermediate risk, or a high risk. And based on the assembly of these various parameters and how they sort into these 3 columns, patients are to be sorted into a low, intermediate, or high risk. It's not necessary, according to guidelines, to collect all data on all these variables at each time, but guidelines state that at least functional class, 1 measure of exercise capacity, and 1 of right ventricular function should be gathered to make this kind of comprehensive risk assessment. The variables included in this risk assessment instrument have all been shown to individually be predictive of prognosis in PAH, both at diagnosis and during follow-up, but there was previously no evidence for this sort of comprehensive risk assessment, and the cutoff values used to sort the patients into a low, intermediate, or high risk group are mainly based on expert opinion. And whereas the recommendation to use this instrument is a class 1 recommendation, that is the highest degree of recommendation, level of evidence when guidelines were published back in 2005 was C, which is the lowest degree of evidence. And also the guidelines propose that a low risk profile should be used as a treatment goal for most patients with PAH, which there is also no was also no scientific evidence for. So our goal when starting this project was to use the Swedish PAH register to test the feasibility of this risk assessment instrument to separate patients with better or worse prognosis and to see whether a low risk profile could actually be a valid treatment goal. In our study we included all incident cases of PAH registered in our Swedish registry from the 1st of January 2008 to the 1st of March 2016, and in total there were 530 patients, mostly IPAH, but also associated PAH, familial PAH. Data was collected from the registry. We collected data on functional class, on 6-minute walk distance, NT-proBNP levels, right atrial area, the presence of pericardial effusion, right atrial pressure, cardiac index, and mixed venous saturation. Both at baseline and for 383 patients who had a registered follow-up performed within a year from treatment start. Data was collected from the follow-up as well, and this follow-up was performed in median 4 months after treatment start. SPAR, the Swedish PH registry, does not include data on clinical features such as signs of right heart failure, progression of symptoms or syncope, which are also included in the risk assessment instrument in the guidelines, so we did not have these data. Neither were all variables present for all patients, but out of a maximum of 8 variables at baseline, there were in median 7 variables present per patient, and at the follow-up there was median of 5 variables present for per patient to be incorporated in this risk stratification. And also approximately 80% of patients fulfilled the guidelines recommendations of having functional class, a measure of exercise capacity, which was 6-minute walking distance in all cases, and some measure of right ventricular function for the risk stratification. To do the risk stratification, we developed a simple equation which was applicable to registry data, where we graded each variable depending on whether it was in the low, intermediate or high risk column. A low risk parameter was graded 1, an intermediate risk parameter 2, a high risk parameter 3, and by adding the sum of all grades for each patient and dividing it by the number of variables available for that patient, we retrieved a mean grade which was rounded off to the nearest integer, and that was used to define the patient's risk group. So a mean grade of 1 resulted in the patient being allocated to the low risk group. A mean grade of 3 resulted in the patient being allocated to the high risk group. So approximately half of the patients included in the study were idiopathic PAH, the second largest group being PAH associated to connective tissue diseases, primarily systemic sclerosis, the third largest group PAH associated to congenital heart diseases, and then there was a small group familial PAH, and a group of with other forms of associated PAH, such as HIV-associated PAH and PAH associated to portal hypertension or drugs and toxins-induced PAH. The median age of the study population was 66 years, which is quite high in a historic perspective. If we look back to registry data from the 80s, 90s and even beginning of the 2000s, but it's very much comparable to more present registry data, for instance, from the Compera. 65% of patients were female, and as a consequence of the higher age, I suppose, there was quite common with comorbidities, with about 40% having systemic hypertension, 20% diabetes mellitus. There were 15% of patients who had either ischemic heart disease or thyroid disease, 14% with atrial fibrillation, and a few who had previously had a stroke. With respect to initial treatments, exactly 81% received initial monotherapy and 16% received initial combination therapy. Out of the patients who received initial monotherapy, among those patients, there were some who received a calcium channel blocker, representing in total 5% of the cohort, meaning that 9.2% of patients with idiopathic familiar or drugs and toxins induced PH were acute responders, which is in line with previous data. And looking at these quite low numbers with respect to initial combination therapy, we should remember that most of these patients were diagnosed and started treatment before the AMBITION study and the 2015 guidelines were published. Okay, so at baseline, there were about a quarter of the patients included in the study who were in the low-risk group, about 2/3 in the intermediate risk group, and 1 in 10 was in the high-risk group. If we look a bit further into the characteristics of the patients per risk group, we can see that the patients in the low-risk group were significantly younger than those in the intermediate or high-risk groups. We see that the patients in the high-risk group had more comorbidities, or at least more severe comorbidities, more diabetes mellitus, more ischemic heart disease, more atrial fibrillation than those in the low or intermediate risk groups. And at baseline, there was a relative overrepresentation of IPAH patients in the high-risk group. If we move on to look at the initial treatment sorted per baseline risk group, we can focus on the blue piece of pie here, which represents monotherapy, and we see as we move from the low risk to the intermediate and high risk group as that this blue monotherapy pie shrinks, and in the high risk group there was only about 50% of patients who received initial monotherapy. So I suppose this in some way validates that the risk assessment that was made by our equation based on registry data corresponded quite well to the risk assessment done by the clinician. Here we see survival per baseline risk group. The blue line represents the low-risk patients, the green line the intermediate risk patients, and the yellow line the high-risk patients. And the risk assessment made appears to succeed well in discriminating patients with a better or worse prognosis at baseline. The patients in the high-risk group have a very poor prognosis, not very much different to that seen in the NIH data from the 1980s, when there were no specific PAH targeted treatments available, whereas on the other hand, patients in the low-risk group have a quite good survival over time. If we move on to look at the follow-up data, at follow-up, 29% of the patients were in the low-risk group, 60% in the intermediate risk group, and 11% in the high-risk group. We can look again at the patient characteristics per risk group. At this follow-up, which was performed, as I said previously, within a year, between the groups, and there seems to be some overrepresentation of patients with connective tissue disease associated PAH in the high risk group. Comorbidities are still more common in the high risk group. And again, the risk assessment performed seems to succeed well in discriminating patients with a better or worse survival rate. Again, the blue line represents patients in the low risk group, the green line patients in the intermediate risk group, and this steep yellow line patients who are in the high risk group at follow-up even after having received treatment. So if a patient doesn't respond to treatment and is classified as a high-risk patient according to the instrument at follow-up, prognosis is very poor, with only about 25% of the patients alive after 3 years. On the other hand, again, patients in the low-risk group have a very good prognosis. So what happens from baseline to follow up if you change risk group? We'll look at this figure here. The blue line representing patients who were stable low risk. They were classified as low risk both at baseline and at follow-up. And this green line represents patients who were either intermediate or high risk at baseline, but then improved to the low risk group at follow-up. You see there is no difference between these two lines. So if a patient responds well to treatment and is classified as a low risk patient at the follow-up, survival is as good as if you would have been low risk from the beginning and stable low risk. And the same goes for if we look at these two lines, where the yellow line here are patients who are stable, intermediate or high risk, both at baseline and at follow-up, and the purple line here are patients who were low risk at baseline but then deteriorated till the follow-up to either the intermediate or the high risk group. There's no difference between these two lines really. So if you're stable, intermediate or high risk, you have as bad a prognosis as if you are initially low risk but then deteriorate. Okay, and here we also looked into whether the and use the number of low risk variables for a patient to determine whether prognosis is better or worse. So the purple line here are patients who have 75 to 100% of their investigated variables in the low risk group. The yellow line represents patients with 50 to 74% of their investigated variables in the low risk group. The green line does with 25 to 49% of their investigated variables in the low risk group, and the blue line those with 0 to 24% of their investigated variables in the low risk group. So the more low risk parameters, the better. We also performed univariable and multivariable Cox proportional hazard analysis, where we found that in the univariable Cox proportional hazard model that patients with a low risk profile had reduced mortality risk as compared to those with an intermediate or high risk profile with a hazard ratio of zero 0.1, and in multivariable Cox proportional hazard models adjusted for age, gender, and pH subset, the results were reproduced with a hazard ratio of 0.2. So what about these elderly IPAH patients? As we saw, the median age in the cohort as a whole was 66 years. We have over the years seen that there are patients who are diagnosed with IPAH when they are older and they have comorbidities, and there's been discussions on whether this is really classic PAH or perhaps a previously unknown phenotype of PAH, or even left ventricular diastolic dysfunction that is missed with current hemodynamic diagnostic criteria. Anyway, we chose also to perform the analysis after excluding IPAH patients diagnosed at an age above 65 years of age, to have a more, well, old style group of PH patients, and the results were unaltered. And we also performed separate analysis for the two largest group of subsets of PH, that was the IPAH group and the group of patients with PH associated to connective tissue disease. And also for these two groups, the results were unaltered as compared to that performed for the entire cohort included in the study. So in conclusion, we found that the risk assessment instrument of the ESC and ERS guidelines appears to successfully discriminate patients with low, intermediate, or high risk, both at baseline and during an early follow-up performed within a year from treatment start. And the low risk profile appears to be a valid treatment goal. Shortly after our study was published, these two studies were also published in the European Respiratory Journal, one from the Compera and one from the French PAH registry. These two studies also looked into the feasibility of using the ESC-ERS risk assessment instrument and a low risk profile as a treatment goal, and the findings are similar as those of us. Here we see a figure from the study by Marius Herper and colleagues using the Compera. They used the same equation for risk stratification as we did, and these are survival rates based on risk group at follow-up. It was a follow-up performed somewhere between 3 months and 2 years from diagnosis. And as in our study, patients with a low risk profile have better survival than those with an intermediate risk profile, who in turn have better survival than those with a high risk profile. Sorry. The study by Boucli from the French registry used somewhat different approach. They looked into the outcomes of patients with 4, 3, 2, or 1 or 0 low risk criteria at baseline and follow-up. And these are the data from the follow-up, and we see that those patients with 4 low risk criteria have the best survival rates, whereas those with 0 low risk criteria have the worst survival rates. They also performed a separate analysis including only non-invasive parameters, that is functional class, 6-minute walking distance, and BNP or NT-proBNP. And again, patients with 3 low-risk criteria at follow-up had the best survival rates, and those with 0 low-risk criteria had the worst survival rates. So what's left to do? It seems from all these 3 studies that has been published so far concerning the risk assessment instrument of the European guidelines, and that the instrument is successful in separating patients with better or worse prognosis, and it seems a good idea to try to treat patients so that they achieve a low risk profile. With these 3 studies, there is now a bit more than 3,000 patients included in the studies. But what doesn't we know? What should we do in the future? Well, the risk assessment instrument has still not been validated in a prospective study or randomized controlled trial. This is still registry data, and although data were consecutively registered, we look at them retrospectively. Also, we looked at the efficiency of the risk assessment instrument at baseline and at an early follow-up within 1, or in the case of the comparator registry, 2 years from baseline, but we still can't be certain it's effective during all stages of disease. We neither know whether more patients actually receive a low-risk profile today as we use combination therapy more than we did before. We don't know whether all variables included in the instrument should be weighted equally, and well, how should we handle other variables also with effect on prognosis, which are not included in the registry? What about gender and the PH subset, age and comorbidities? That has to in some way be has to be taken into account in some way as well. And perhaps most importantly for the clinician who has a PH patient in front of him or her, how should I use the risk assessment instrument in my daily practice for this specific patient? I mean, these are data on a population basis, but how to use it in practice? Maybe we can discuss some of these things now in the moderated session. We know more today than we did only a year ago with respect to this risk assessment instrument, but there's still a lot that we don't really know and that we have to think about in our daily practice, trying to do the best we can for our patients with PAH. Thank you for listening. Yeah, and right. Some of these questions are discussed in this editorial that was published together with our publication in the European Heart Journal. That's why I have that here, so you can look that up and read and think about it quietly at home. Forgot to say that. Okay.
So good. Thank you very much, David, for a very good presentation. And we are very happy to see you back in Lund, where you belong.
Yeah, okay? But tomorrow I'll be back in Linköping. I think my boss is watching.
We are waiting for questions from the various sides, but we could start with some questions from in here if anyone sitting has a question. Then we have a microphone that we will pass around. Any questions from the audience here? Even hold the microphone very close to your mouth, and I can hear you.
I can hear you.
You have specified 3 patients, one low risk, one intermediate risk, and one high risk.
Sorry, how many
You have
patients?
identified 3 different patients.
Yeah.
One low risk
Yeah.
patient, one intermediate risk patient, and one high risk patient. What would differ in the when at baseline? How would you treat these 3 different patients now? From what would you give them for treatment?
Yeah. Well, asking the right person, right? Well, I don't think you can answer that simply, right? You have to know what patient is this. Is it a 85-year-old woman with diabetes and a previous stroke, or is it a 15-year-old girl who's otherwise healthy? In the first case, maybe you don't start all through roughly. With the second patient, maybe it's time to go in with triple therapy already from the beginning and start planning for a lung transplant. So, I mean, it's all about the clinical situation. You can't just only look at whether this patient is in the green, yellow, or red column. It's one piece to look at, but you also have to see the whole. Who is this patient? Right, you agree?
But you have 3 patients. They are all women, and they are 30 years old, all of them.
I think,
Yeah.
I mean, the risk assessment strategy is a help for us to group the patients in different groups. And if you have a patient that is in the red zone, we can be very aggressive with regards to treatment. We can start intravenous therapy together with perioral therapy. If you are somewhere in the low or intermediate risk zone, you have to make individual choices with respect to the patient that you have in front of you. I think, in principle, no matter whether you are in the low or intermediate risk zone, you should start with combination therapy early. And you should early also re-evaluate your patients already after 3 to 5 months to see if the patient has stabilized, improved, or maybe even deteriorated. And then you have to be even more aggressive with regards to adding therapy on top of that. So I think you should work with this along with sort of the risk assessment strategy. Further questions from the audience or from the different sites? Jonas has a question here. And this is a question that is coming from Gothenburg, Sven-Erik Bartfai. So he says 6-minute walk distance could be an important variable, but depends a lot on the age of the patient or if the patient has scleroderma. We might treat an old PAH CTD patient intensively, but will never be able to get the patient to walk longer. And not seldom is short walking distance caused by something else than PAH. It would be interesting to see a study on 6-minute walk distance stratified for age and comorbidities. Is there something in the pipeline is part of these questions? Or comments on 6-minute walk distance as a variable in the risk stratification model. Do you want to start, David?
Sure, I can start. Again, in my opinion, you can never just look at one parameter, and you have to put it into a context. Of course, an old little man or woman with a bad hip can't walk as long as a young girl, even though they might have the exact same variables beside the 6-minute walking distance, and that's why you can't risk stratify a patient based on one variable. You have to investigate many variables and put all of them into their clinical context. Which is also put forward in the guidelines. You should do a comprehensive risk assessment, which should incorporate at least functional class, some measure of exercise capacity. Doesn't necessarily have to be 6-minute walk distance. You can also do a cardiopulmonary exercise test, for instance. As a clinical physiologist, I'm very fond of this exam. It's much better than the 6-minute walk distance. But I also realized you maybe can't do that with every patient. And you should investigate some measure of right ventricular function. And if you can't trust the 6-minute walking distance, well, then you have to look at all the other parameters.
So 6-minute walk distance is one of many parameters that we can measure, and many young patients that high PVR, they can actually walk a very long distance also. So then maybe it's not a good measurement, but that's why we need to have many different parameters to look on. And I don't know whether the type of study that he is proposing is in the pipeline or not. We haven't discussed it really. So, further questions from the audience? Jonas has one more, or anyone else? Dirk?
Little bit in line with this, how many parameters you use. You showed this one study which has used the non-invasive parameters. Have you looked in how your study in comparison to their studies? I mean, if you would do their studies and apply to your cohort, would it be as good as your study?
I'm sorry, I'm not sure.
If you use just the non-invasive parameters in your cohort, would the performance be as good than if you would, than if you use all the invasive parameters?
I don't know, because I haven't done the comparison. It's not at all patients in our cohort who has performed invasive hemodynamics at the follow-up. We do that, or we, no longer I, but the colleagues here in Lund do that regularly, but at the other centers in Sweden, right heart catheterization is not done at every follow-up assessment, so much of our data is mainly based on non-invasive parameters as well, although not exclusively non-invasive variables.
To give a brief answer of your question, there are 3 studies now: the Swedish PAH register study, the French register study, and the compare register study. And in the French study, in the main study, they looked on functional class, 6-minute walk distance, mean right atrial pressure, and cardiac index. And then they were studying about 1,000 patients. Then they did actually a non-invasive sub-study as well, looking on functional class, 6-minute walk distance, and NT-proBNP or BNP on 600 patients. And that study also were able to differentiate that the patients that were in a low risk did much better than in a high risk, whether it was at baseline or at follow-up. So I think the non-invasive parameters may help you a lot as well. It's better to do something than nothing. Further questions? There is one question here from somewhere in Sweden. Several publications have been published recently, and Buckley et al. Suggest to use 6-minute walk distance, NT-proBNP, and functional class. And that's exactly what we said here, the non-invasive parameters. If we are waiting for worsening symptoms and NT-proBNP only, we might delay the chance to slow down the progression. What benefits and risks do you see using only symptomatic variables to measure risk? Would you like to start, David, and I continue? I can start. I think you benefit a lot by utilizing more parameters than only the non-invasive ones. The more parameters you look upon, I think it will be easier to find whether the patient is deteriorating or not. I think it's very important as you initiate treatment that you do a very early follow-up after 3 to 5 months. As soon as the patient is stable, it may be possible to have the patient coming on yearly control. But as soon as you find a deterioration, you're back to intensifying therapy and make a quick follow-up again. I think we benefit of having a look on many parameters. But if you can only do the non-invasive one, I think that's good also. I mean, you just have to have something to follow the patients with.
And we shouldn't forget what is not included in any of these studies, and that's asking the question, the patient about symptoms and investigating the patient for clinical signs, because that can also give some hints, although it's not incorporated in these register-based studies. Oops.
Since we have the slide up here, we can compare the studies. The largest study is the German study, looking on about 1,588 patients. The French study studied either 1,000 or 600 patients, depending on whether they were looking on the small non-invasive group. And David studied 530 patients at baseline and then 383 at follow-up. With regards to the parameters, the German study studied functional class, 6-minute walk distance, NT-proBNP, mean right atrial pressure, cardiac index, and the mixed venous oxygen saturations with they got from the right heart catheterizations. And David, he did the same, but he also added the right atrial area and the pericardial fluid. In the French study, they studied fewer parameters with regards to risk assessment. But all studies are pointing in the same direction. Yeah. Do we have any incoming phone calls or more questions that we should bring up? Mikael or Jonas? Jonas has another one. How to identify risk group. According to some European experts in PAH, they claim that one parameter in intermediate yellow or high red risk would qualify the individual patients to belong to either of these groups. From a clinical standpoint, that at least doesn't mean that the patient will be undertreated. Please comment on that.
Well, it's what we've been into many times now. I think both you and I are of the opinion that one should look at as many parameters as possible and set them into their clinical contexts. As we discussed just a little while ago about the 6-minute walking distance, it can be short, but it doesn't necessarily have to do with PAH. It can be something else. So I think you should probably do a general judgment of all the parameters you've investigated that are incorporated in the risk assessment instrument, but you also have to look at other things which affect prognosis, such as sex and gender and the PAH subset, comorbidities, and so on. It's complicated, and you need clinical judgment, and as well, you can't just look at one parameter and think that you easily can sort a patient into a risk category. It's more complex than that, in my opinion, at least.
And these questions also raise the questions with regards to the different parameters. Do we know that any of the parameters are more important than anyone else with regards to follow-up?
Not really, no.
And maybe we should do a study where we sort of try to weigh the various parameters against each other. Further questions? This is from your boss, David.
Oh.
When are you coming home?
Yeah, my train's departing at 19:18, so I'll be home tonight, and I'll be at the office at 7:30 tomorrow morning.
Okay. He has another question too. What about the high-risk group? They are older and more comorbidities that we can't do anything about, and still you give them a better life. Comments?
Sorry.
The high-risk group.
Whoop.
They are older and have more comorbidities, and still you give them a better life, question mark.
Hopefully we do give them a better life, or you. I mean, these older patients with comorbidities aren't really included in any of the clinical trials on pH-targeted treatments. So do we really know what we're doing at all? I mean, what's your clinical experience
With regards to
the older patients with comorbidities? Do they get a better life when you treat them with pH-targeted medications?
I think that's an individual question. Also, yes, if they respond to therapy, but then they have a true pH, and then you give them a better life.
But some of
symptomatically.
them, but some of them don't respond to treatment,
and then we don't know if we give them better life.
No.
If we initiate treatment and we see no effect of it in the elderly group with many comorbidities, then we have to reevaluate whether it is a true pH or not, or whether it has to do with a more diastolic dysfunction, naturally. Further questions? Are we on time, Jonas? Hello, Lund. Nice presentation, David. That sounds good.
Thanks.
This is from Magnus Nissell at Karolinska in Stockholm. Since our results seem to suggest that it is safe to treat and monitor a response and act accordingly, do you think treat to target is a better real-life approach than upfront combination?
Is it really? Does it necessarily have to be in contrast to one another? Perhaps not. I mean, we treat to target, we try to get as many variables into the low risk column as possible. And supposedly we get there the fastest if we use upfront combination therapy.
I think you have the answer in one of the publications that you have written before, that very few patients reach target with only monotherapy. As you looked on all our patients in Lund in between 2000 and 2011, you saw already at the first follow-up after 3 months, about 40% of the patients had to be escalated to combination therapy. And I think in order to reach target early, which seems to be what you have as an we seem to be an aim with the studies that has sort of been exemplified here today, then I think we should start with the upfront combination therapy. That's my opinion.
I mean, even though patients in the low-risk groups of these 3 studies appear to do quite well and live quite long, I mean, it's still a very serious disease, and we can't not treat them just because their status is okay at the beginning, and maybe they're low risk from the beginning. But I mean, we know the disease will progress, and I believe there are really very few patients with all variables in the green column from the beginning. So,
should we think different with regards to different patient populations? In your cohort, you have the normal pH patients, but you also have the C/D pH patients. Should we treat them differently or the same? How should we think about those various groups? Or we can ask Roger, do you have an opinion? Should we treat your patients different from ours? Should we be even more aggressive?
Yes, that was what I was thinking about, but I'm not sure how we should be more aggressive, because I was thinking about initially the question from Øyvind. So I was thinking, should we use more drugs up front, or should we intensify the follow-up with seeing the patients more often to escalate the treatment quicker in the beginning?
And with your reasoning today, how often do you see your patients?
Right now, we usually see our patients after the baseline investigation. You do a new right heart catheterization after 3 to 6 months, and then after that we see them every 6 months. But I think it would be beneficial to see the patients more often, at least in the beginning, if they're in the yellow zone.
Do you think you should have sort of a telephone follow-up every second month or something to see whether they give signs of deterioration and then maybe take them in earlier? Or do you think you should follow them monthly basis with an NT-proBNP and see if you get a signal from that?
I think we have too little information by just a telephone call or a proBNP. I think it would be better to do the whole examination, but a little bit earlier, because I was intrigued to see that the patients that had moved, if you compare the idiopathic PAH and the connective tissue diseases, you saw that many of the patients who belonged to the idiopathic group, they had moved from the red to the yellow, or from the yellow to the green, whereas the connective tissue diseases, they had deteriorated despite therapy. Exactly why it's like that, I'm not sure, because that population is a little bit older as well, so they're not completely comparable.
So in the present treatment trial where we look and compare upfront triple with upfront double combination therapy, do you think your patients are going to be even more responding to the triple therapy there? Is it going to be more decisive for that group?
I'm not no, usually they're not more responsive, but perhaps they would still benefit by a more close follow-up.
Further incoming calls or questions? I don't know who this is from, but patients with CTD-PAH are often more sick, have several comorbidities on top of their scleroderma, often with affected lungs. If using risk stratification on those patients, the majority would end up in an intermediate high-risk group. What is your comment on that when it comes to risk and treatment? You want to keep the microphone? No? David?
Yeah, well, it's a risk factor from the beginning to have systemic sclerosis and PAH. They have a worse prognosis than idiopathic patients, for instance. And of course, it's not good if all the variables are in the red column. Not when it comes to patients with systemic sclerosis, rather connective tissue diseases, and not when it comes to any other patients with PAH either. But perhaps, as we said before, systemic sclerosis or CTD patients with PAH should be treated more aggressively from the beginning. If we look at our data from this study, I think at baseline the CTD-PAH patients were actually overrepresentation in the low-risk group, perhaps because there is effective screening, but still at the follow-up within a year from treatment start, in median 4 months after diagnosis was set, there was a quite severe overrepresentation of these patients in the high-risk group. So it seems definitely, as we know, to be a more aggressive form of the disease, and why shouldn't we treat them accordingly? Well, perhaps there are other factors playing a role there with respect to tolerating too many treatments at a time, but Roger is maybe into something good there with closer monitoring of the patients, and now he wants to reply, so that's good.
Just a short comment, because I think it's really intriguing that the patients with connective tissue diseases, although they may have a better cardiac index and lower pulmonary vascular resistance, they have a higher risk of dying, despite that what is driving their disease is something that's not related to PAH. It's lung fibrosis or diastolic dysfunction or anemia or whatever. So I think it's important when you assess these patients not only to focus on PAH drug, but to focus on everything else as well. To treat the heart and the musculoskeletal system, make the patient stop smoking and everything you can do, because it's very often multifactorial.
I mean, the whole risk assessment approach is based on expert opinion, but also the parameters, the magnitudes of them, they are also based on expert opinion. Should we have different cutoffs for the CTD group? Different cutoff level for NT-proBNP or 6-minute walk distance or functional class and so on?
Perhaps different for different diseases, or perhaps different for different ages.
Further questions? Here is a validity question. Incident versus prevalent patients and risk stratification. What are your thoughts on this? Further, any comments on how often you would recommend that a risk stratification should be performed? Could you start with the first one?
Yeah,
Incident versus prevalent.
Yeah. Well, all studies that has been performed so far, these three incorporate only incident cases of PAH, and it is based on risk stratifications at baseline and at a quite early follow-up. In the case of our study, within a year from baseline, and the same goes for the French registry, whereas the Compare study incorporated a follow-up performed somewhere between 3 months and 2 years from baseline. So we only have data on incident cohorts, and we only have data on early or quite early follow-up after diagnosis. Whether the risk score is applicable for a prevalent cohort, if you can use it as efficiently, no matter what the duration of disease, I don't know for sure. Perhaps not. Maybe you can use it to follow changes, and you can see if a patient is deteriorating or if he or she is responding well to a new treatment. But if you can just use it at any time without consecutive measurements following trends, I don't know. No one knows.
And then any comments on how often you would recommend that the risk stratification should be performed? Basically, what the guidelines tells us is that when we initiate treatment at baseline, we should follow the patients up after approximately 3 months. And then as the patients are stable, we should follow them after about 6 to 12 months on a regular basis. But I think when they deteriorate and as we intensify treatment, we have to follow them again after 3 to 5 months until they are stabilized. If they are on maximum therapy and they still deteriorate, then we have to think about pulmonary transplantation investigation as well, naturally. And then always you have to individualize the follow-up for each patient, I think. I believe it's extremely important that the patient has the possibility to call into our PAH nurses and say that they are feeling worse, and then they can come in for a very quick checkup. And that maybe could be a non-invasive one to make a decision whether we should do an invasive follow-up as well. But it's very important that they have a easy access, I think, to our PAH nurses in the follow-up. There are still questions rolling in. This is the last question. To conclude, this must be for you then.
Okay.
How do you see
Let's
that the risk stratification could or should be used in clinical practice? What parameters would be recommended to prioritize and why? From the Nordic audience.
Okay. In my opinion, it's my opinion, but I think the recommendation by the guidelines is quite reasonable. That you should determine functional class. You should have some measure of exercise capacity, some measure of how the right ventricle is working, at least, and then as many variables as you can get, the more, the better, I think. And perhaps you can't gather them all every time, but perhaps after you've done some alteration in treatment, or if the patient's feeling worse, and then in between maybe you can be satisfied with just the non-invasive parameter from used in the French registry or so. What do you say?
I'm tired.
Yeah, me too.
No, I think I look upon the risk stratification as a tool to follow the patients. We have used the same parameters before, looking on prognosis. It's hard to know whether the patient is fully green, fully yellow, or fully red. They are somewhere in between. And then you have to look upon this patient really as an individual and make a choice. But the risk stratification tool is a help. And if we collectively look on the 3 publications, David's paper says that 5-year survival is based on risk group at baseline, as well as at follow-up, and the change you see from baseline to follow-up. If the patients are in the green zone, they do much better than if they are sort of in the red zone, the high-risk zone, and the same goes for follow-up. And David's paper also said that the 5-year survival is based on proportion of variables in low-risk group at follow-up. So if you have more than 75% of the parameters in the low-risk zone, you do much better than if you have less than 25% of the parameters in the low-risk zone. The paper by the French group, they say that you have a better transplant-free survival at follow-up, the more low-risk criteria you have, and also with an improved risk profile. So if you, from the beginning, for instance, have 3 low-risk criteria, but you, upon treatment initiation, afterwards have 4 low-risk criteria, you will do better. And the French group also say that you have a better transplant-free survival at follow-up, the more non-invasive low-risk criteria that you have. So if you have 3 low-risk criteria at follow-up, you do much better than if you have 2 or 1 or none. So really, if you intensify treatment and you put the patients in the zone where they have as many low-risk criteria as possible, they do better. The German group, they say that you have a better survival with low risk at baseline and at follow-up. This goes with David's paper as well. And you also have a better survival with improved risk profile at follow-up. Patients that from the beginning are in the low risk group, or if they improve to the low risk group after initiation of treatment, will do both will do good. If you are in the high risk group, or if you deteriorate into the high risk group, then you will do worse. So I think collectively all those papers, they will, as we come to the World Symposium in Niche in the end of February to March, sort of emphasize that now this risk stratification tool is not only based on expert opinion, it's actually based on 3 different studies that independently has showed that it's a good tool for us to use in the clinics. So David, now you are the expert. We're basing it on you. You are the expert opinion. Do we have any more questions coming in? Otherwise, I would like to just say thank you everybody for listening to this PH Risk Assessment Symposium and the winter webcast here from Lund. And we're soon going to go out and ski here in Lund, all of us. So thank you very much.
Thank you.
Thank you.